don't think there's any announcements, at least that I have for today. Quiz Thursday, practice quiz should be open now. I apologize, I got these slides up late this afternoon, but hopefully they're accessible and didn't need them before now. So, any questions or anything before we jump right into this, the second portion of the cannabis lecture? So today's going to be more focused on the clinical or medicinal application of cannabis and cannabinoid molecules. Talk about a couple of disease states that it can be used in, and then a couple of therapeutics that have been marketed. Finishing with a discussion on scheduling for drugs, just to kind of cover that in this section. But, no questions? Let's just dive in. So, we talked about this last time, right? When talking about or discussing cannabinoid molecules, there are essentially two sets of receptors, CB1 and CB2, that they hit, all endogenous and exogenous. Cannabinoid molecules signal through these two receptors, both GPCRs. CB1 is primarily located centrally, CB2 primarily peripherally, and as we discussed, these are retrograde type of transmissions where once the endogenous cannabinoid signaling, once a signal or neurotransmitter is released into the synapse, the postsynaptic neuron is responsible for synthesis of endocannabinoids, which are then released and act on receptors in the membrane of the presynaptic neuron membrane, right? And then likewise, exogenous cannabinoid molecules will act on those molecules there, but they act on presynaptic nerve terminals to essentially freeze those nerves down. So that's a quick summary of last lecture. This time we'll discuss a little bit more detail, some of the downstream effects, and talk about CB1 and CB2, but primarily revolve around CB2. Well, that's not true. Some cases we'll have more of a discussion of CB2 binding and activation. And as this slide shows, well, let's back up here. So we discussed last time CB1 is the primary driver for the psychotropic effects of THC specifically, but endogenous and exogenous cannabinoids bind to this receptor with higher affinity. It being a GPCR, which is bound to G-alpha I, will inhibit adenylate cyclase activity, decreasing cyclic AMP levels, and then decreasing downstream PKA, or protein kinase A activity. I'll talk about why that's important in just a moment, but the other things we said were calcium channels are blocked by activation of CB1. Potassium channels are activated by binding of CB1 to a cannabinoid agonist, okay? So all this, these three different outcomes happen when you have agonist binding to CB1. Similar in CB2. Again, it is also coupled to G-alpha I, so it blocks adenylate cyclase and similar downstream effects, okay? But why we should care about that, just kind of in general, or looking at a very hypothetical, general situation. In normally functioning immune response, when you have activation of the immune response or a pro-inflammatory cascade happens, once a pro-inflammatory molecule binds to a receptor that can then activate adenylate cyclase, so this would be a GPCR coupled to G-alpha S, stimulates adenylate cyclase, and then we have the whole downstream effect. Increases cyclic AMP production, that triggers protein kinase A, and then if you remember this schematic from discussing alcohol and the common response or body's normal response to stress with the CRF, pro-stress expression or neuropeptide being able to bind to its target receptor. Adenylyl cyclase, adenylate cyclase, these are the same enzymes, just two different names. It depends on who you read, depends where you train, depends when you train, really. But just know adenylate cyclase, adenylyl cyclase are the same thing. Yes, but you have activation here of this jobber, and then production of cyclic AMP, and then activation of PKA. And what we talked about before was inactive CREB then becomes activated. Same thing here. Nuclear factor B, kappa B, or NF kappa B, is the same as CREB here. So this is a transcriptional element that will actually sit on a promoter sequence of a gene, blah, 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 blah. Idea here is that once PKA activates nuclear factor NF kappa B, turns on pro-inflammatory gene expression. Here we talk about increase of NPY activity or production. In the example today, we're talking pro-inflammatory gene expression is upregulated, okay? So, just relating this to an earlier lesson, but same type of cascade with a different final transcriptional factor being activated. This is normal pro-inflammatory pathway, okay? With activation of CB2, however, since we covered this is coupled to G-alpha-I, that will inhibit adenylate cyclase. So all of this gets shut down. And it can even tamp down the response of normal pro-inflammatory molecules binding to their target receptor, okay? So the idea here is that with THC on board, binding to CB2, it shuts down adenylate cyclase activity, and this whole cascade of events happens is, it's not usually completely shut off, but it's tamped down considerably. And the idea that we talked about right at the end of last week, or last lecture, was this is an anti-inflammatory molecule, right? So this will stop the pro-inflammatory response through this mechanism and prevents gene expression of pro-inflammatory molecules, all right? So that's CB2 activity when bound to THC. Why we care, we'll jump right in. So Crohn's disease, inflammation that affects parts of the small intestine. This is an inappropriate immune response to normal gut bacteria, and then other things people hear a lot about. The more we understand about how our diet affects things, but this can be a hereditary condition. And the overall manifestation of this disease, diarrhea, intestinal bleeding, abdominal pain, weight loss, fatigue, is bad. It's real bad. However, cannabis has been used in the treatment of this disease. So, in this lecture, there's going to be a bunch of data and tables. You're not responsible for any of that. I just give them to support what the point of the slide is. So you have the data, but you're not going to be tested on the data. Usually the point of the slide should be in the title or somewhere apparent. So, cannabis use improves Crohn's disease. So Crohn's disease activity index, CDAI. While plotting this, we have our CDAI here on the y-axis. Time of treatment on the x, and as you can see here at the initiation of this study where we have placebo group in white or blank bars, and then the gray or charcoal bars is the treatment group where they're smoking cannabis. Dose doesn't really matter for our purposes, but they're on the weed. So you can see at week 0, we kind of have overlapping CDAI scores. The longer that the subjects progress through this study while using cannabis, the better their outcome is. As you can see, the controls vary very little, but cannabis users show a drastic improvement. And then washout is when they just stop the experiment and they get no more treatments, and you can see they return back to the higher levels Yes, please.
Is CDAI, is that just symptoms of Crohn's disease? Is that?
Exactly.
Okay.
So the CDAI activity index is, a subjective questionnaire. How much, not how much diarrhea do you have, but yeah, how, are you affected by it? So yes, exactly. It's going to be a questionnaire about the specific symptoms, and then the participants will evaluate themselves in terms of how they're feeling. Right, so as long as you're on the weed, you're feeling better in terms of Crohn's disease. Once you go off it, everything goes back to normal. And, excuse me. So looking at different negative and positive side effects, the overall point is that cannabis kind of improves them across the board. So using, yes, please.
Is it just smoking or like gummies or?
In this study, yes. So is it just smoking for this study? Yes, but you can replicate these now with edibles for sure. It's more about having not just the active THC on board, but other cannabinoids help in this field. So, yeah. So, moving on to seizures. This is a hot topic and has been for quite a while. There's been anecdotal evidence that cannabinoids will improve seizures in children and adults. We've known that for decades, but it's only the last really 20 years, 15, that people have been studying it in a very honest and upfront way. And it's primarily CBD here. So cannabidiol is the main active molecule that treats seizures, and the explanation is from this paper. Came out about 5 years ago. If you'd like to read it, it's actually a good summary of this. But the idea is that in normal seizure conditions, you have an increased glutamatergic tone, where glutamate is activating AMPA receptors, okay? And then there's a certain amount of downstream signaling that happens that is kind of aberrant and out of control, if you will. But the idea is this is controlled by glutamate transmission in the brain. And then if you treat with CBD, what they've been found to do is actually the CBD molecule can stabilize certain subunits in the AMPA glutamate receptor, causing a decreased amount of downstream transition. And the overall effect here is that there's a decrease in seizure activity. So, yeah, that's how the molecular explanation of how CBD can decrease seizure activity in humans, in any animal models, really. So this is just shown as proof of concept. Again, you don't need to know all of this, but looking specifically at childhood epilepsy, because this is a really big space that has a number of different drugs that are approved for the market, but they're really crappy. I mean, they work to decrease seizure frequency, but terrible side effects with these. And this is a really heartbreaking one. Looking at these, so these are all underage children. Primary Lennon-Gastaut and Dravet syndrome are the main types of seizures they're undergoing, but you can see the different age of the people that were analyzed in this study. And most heartbreaking, most of them were starting to experience seizures at less than a year of age. You can see, so this is a mixture of CBD and THC used here. But the most heartbreaking thing is the number of seizures prior to this study. The one on the top, over 100 seizures a day, but then when using this cocktail of CBD and THC, brought their seizures down to 8 to 10 a day, which still sounds horrible, but the difference between over 100 and 8 to 10 a day is, I mean, it's incredible. And as you can see, the very last column here, estimated change in seizure frequency, a lot of these patients are experiencing well over 80% reduction in seizure activity, and that's just, I mean, just phenomenal. Anyway, so cannabidiol, and here enriched with THC, can be used to treat childhood epilepsy. More specifically, or a different analysis of Dravet syndrome, specifically just with CBD, is shown here, and won't go into all of the data, but just brought this up because, as I said, most of these subjects are already on an average of 5 anti-epileptic drugs, and they have a number of pretty horrible side effects. So they have been shown to statistically decline the frequency of seizures, but it's always a kind of a trade-off between if you could deal with the seizures and put up with the side effects, as some subjects have side effects that are so severe it's worse than the seizures they undergo. But a great space for a drug that would kind of wipe out all of this. And yeah, so outcome from this study again, CBD in Dravet syndrome, and just want to mention this portion here. So baseline for cannabidiol group is about 12 seizures per month, reduced to essentially half that, or they're saying it's reduced by 40% through the study. Placebo would be without CBD, obviously, but on the drugs used to treat seizures. So there is a statistical reduction in the amount of seizures that this group has seen, but again, the different types of side effects are much more drastic than side effects from CBD are. They do happen, but they're more in terms of some people become insomniacs, or some problems with nausea and upset stomach, but in general, much fewer and more mild side effects compared to approved medication for seizures. So, now, that's all good, but it's not all good in this world, right? So we have to remember there's good and bad. THC has been shown to impair spatial learning in memory and in mice, and this is a study that shows exactly that. So we'll talk before about this swim test, the Morris Water Maze as it's called here. So you have kind of a large dish of water, usually put like chalk in it or that, so you can't, like a mouse that's submerged in the water couldn't just see the platform and swim over to it, right? So you got this big dish with water in it, and there's a platform that they're supposed to find, but you usually color the water so they can't just see it and swim over to it. The idea is that you put the mouse in there and it'll swim around, swim around, swim around, checking out the place, and then it'll find the platform so it doesn't have to swim and it could stand on it. So if you look here, look at this top saline row. In adolescent and adult mice, you see on day 1, you drop them in the water and they swim around, swim around, swim around, and they'll find it eventually. As you can see, by day 5 in this experiment, they've been in it enough, they know right where to go. Whether they're adolescent or adult mice, first day they're hunting all over, by day 5 they remember right where it is, so they can essentially just go right to that spot and do it. Not so much with the adolescents and THC on board, okay? So we have the same kind of wandering around on day 1 as we saw in the control, but adult mice were much more adept. Even though they were on THC, they remembered that they can go right to, there's not a lot of difference between these two. Adolescents, it's much more impacted. You can see there's less ability to remember where they need to go with THC on board. So, THC can impair spatial learning in mice, especially in terms of adolescent brains, right? Oh, this YouTube channel is a video on this swimming test if you're interested in seeing that. Now, on top of that, THC suppresses gamma oscillations in the brain, all right? So, gamma oscillations, usually between 30 and 90 hertz. These are radio frequencies that are emitted by the brain during specific times that help tie different areas of the brain together, but they're usually emitted during times when you're forming memories or you're learning something. There's specific activities that the brain will start generating these gamma oscillations, and as you can see on the right, Auditory stimuli at around 40 hertz is being recorded. Auditory stimuli is being provided to patients, and then EEG or electroencephalogram is reading 40 hertz emittance from these brains, and we have the control subject that have a certain level, and then cannabis users at a much decreased level. So all of you heads out there that want to go to the dispensary and pick up some product before you study all this subject matter, you can forget it, right? So you got to learn it. You got to be up here, not down here. All right, I'm not here to give you medical advice. You're all adults. You do what you want. But just remember that it's been shown that THC can suppress gamma oscillations from our brains, and this can be detrimental to things like learning and forget the rest. So. All right. This just shows that same thing. But yeah, so, okay. You don't need to worry about this data once again, but when I was looking at this data, I really didn't care for something because, as you can see here, so this is a supplementary table to the study we just saw, and they have controls and they have users. So the users are the people that are using the cannabis, and then the controls are not. But if you look down here, average number of alcoholic drinks per week, maybe 1 for the control and 5 times that amount for the cannabis users, all right? So what's another drug that can affect gamma oscillations due to inhibition of GABAergic neurons in the brain? Alcohol, very good. So back when I used to actually do bench work, I would consider this a confounding factor, and I don't exactly understand why I went ahead, but they're still saying it's the THC that is affecting the gamma oscillations, so just remember that. You'll go far. So, all right. Actual pharmaceuticals here. There are a number that were marketed, and a lot of interest in this space has gone away with the legalization of cannabis in this country and worldwide, really. But we still should cover them just for sake of completeness. Dronabinol, Nabilone. Dronabinol is a synthetic THC that was synthesized and then immersed in sesame oil. This is used for attenuation of nausea for people going through chemotherapy. As we saw, THC can tamp down the nausea, and it can increase appetite in people undergoing this, so it's an oral drug. Right, so for these drugs, just know the generic name. So in parentheses is the trade name. Just know the generic name, what it is, like the formulation. So a synthetic THC and sesame oil is dronabinol, what it's marketed for, and then how it's administered. Is it a pill? Is it a solution? Is it a spray? Know those 3 things for each of these drugs. Where it's marketed and status, not so important. And then any kind of anecdotal stuff won't be so important, but just know those, okay? But that's dronabinol, Nabilone, synthetic analog of THC again. Well, this is an analog. So this is actually THC that's synthesized and immersed in sesame oil. This is an analog, and Nabilone is shown here, the structure of which is shown there. This is for same space, right? This is for people undergoing chemotherapy that are nauseous and don't have an appetite. So both of these drugs are released in the same space, but the difference is one is actual THC and one is a THC analog. Both are oral medications. I don't know if people see these much anymore, but they're still marketed. So Rimonabant. So this is a CB1 receptor antagonist, and this is a really interesting one. Here's the structure of this jobber here. So this is an antagonist of CB1, so it freezes that receptor. Used for complementing diet and exercise for treatment of obesity. So if you remember talking about how the brain can produce orexin for feeding, whatnot, CB1 will inhibit all of that, so orexin is released and cause people to eat. If you block CB1 receptor is the thought, then your brain won't be producing orexin and you won't have feeding behavior or won't have a drive for it. However, whoever developed this, yeah, Sanofi, that's awesome. Normally function CB1 receptors have to, we have to have those functioning in our body for just standard endogenous cannabinoid signaling. If you don't, you get in a really bad way, and the Forsate on that just blew me away. But whatever, what I think, they rejected this due to the fact that people were getting suicidal in the trials. And post-launch, actually, people were developing these horrible depressions and suicidal tendency, as well as nausea, because you're blocking the CTZ zone in the brain. You're not allowing anything to tamp down nauseous feelings. So these people were having side effects of this drug that were way worse than, prior to taking it. So this got pulled. This has been a while for this one, but yeah, it was an interesting study. So Rimonabant, bad. Cannabinol, oh. So this one, Epidiolex, is cannabinol. It's just a CBD formulation in suspension. So you take it in a syringe like a lot of kid medications, though it is for anyone 1 year or older, primarily for treating specific childhood epilepsies, but can be used by adults as well. And the idea that this came up with is, or the reason that they went through with this was that you can go to dispensaries and get CBD oil, but there is a big kind of push and pull right now. Areas that have medical and recreational marijuana legalized have CBD oils and gummies and things like that, but the actual quality of them can be suspect, especially in places like California. I think Washington's having an issue where there's a lot of illegal shops popping up, and there's so many dispensaries, it's rare that any law enforcement will come in and ask for their paperwork and make sure they're legit. People will just stop, they'll see a shop open on the corner and move in and start selling weed and everything because it's so easy to get and all of that. But the idea is that it's not FDA approved CBD or FDA approval quality CBD, and that's why this has been marketed by Jazz. A lot of studies that show reduction in seizures due to CBD oil, covered that already, but this is one, that is still marketed here with that rationale that you're getting FDA approved CBD molecules, and you don't have to run the risk of if it's clean or not. And the last one, Sativex. So this one is another combination of THC and CBD used for treating multiple sclerosis, and marketed all over the place, but this is a spray. This is the only drug that's an actual, as it shows, oral mucosal spray. So Sativex is the one, and that actually is the trade name. I should call this Delta 9 THC CBD, but let's just call it Sativex because there's so many that are just that immersed in oil or something. But one thing that sets this apart is this is an oral mucosal spray, so you don't have to take a pill or syrup or smoke anything. You just spray it in the mouth and it's good to go. And yes, so again, side effects are reported to be lower than only Delta 9 THC. I don't know why that didn't come through, apologize. However, that's kind of a hanging chad, if you will. I don't know that that's how good the statistics are on that. But just remember, oral spray for multiple sclerosis, and to that end, MS is an autoimmune disease where the immune system is dysregulated and it causes demyelination of nerves. I've got to imagine everybody here is familiar with this by now, but MS can cause fatigue, weakness, muscle spasticity, difficulty walking, etc., etc. It's the anti-inflammatory effects of the cannabis can help relieve these symptoms, as shown here, but this is actually evaluating Sativex. So what they're looking at is an NRS spasticity score, so just the evaluation of the muscle spasticity in an MS patient. And these are real crappy data. I mean, all the overlap in these bars here, but there apparently is a statistical improvement when using Sativex versus placebo or uncontrolled treatment. So out to 6 weeks is the study here, but just remember that. Sativex combo THC CBD spray is used to treat MS and improves their spasticity scores. Let's skip questions. Okay, any questions on that material? Hopefully straightforward. Okay, as far as drug scheduling goes, just a quick primer on this. So, as you're all aware, the Drug Enforcement Administration is responsible for scheduling drugs that are available, both the illicit drugs and the prescribed by doctor drugs. Schedule 1 through 5, and it's determined by their abuse potential and their potential for medical use, okay? Schedule 1 has the highest abuse potential and no accepted medical use. Heroin's still there, LSD, we'll get into that, and our hallucinogens. And this is where marijuana is. Cannabis is currently still Schedule 1. 2 is high abuse potential, but there's a little medicinal use. So some of the opioids that we'll get into next time, and then our favorite Adderall is in there, of course. 3 would be moderate abuse potential, but some accepted medicinal use. So anabolic steroids that we're going to get into, ketamine as well. 4, and yeah, as it goes on, you keep switching these. So there's lower abuse potential and more medicinal use. The higher the schedule rating, the lower the schedule rating, the higher abuse potential and lower medicinal use value. But for some of our, the CNS depressants like BDZs are here, and then 5, the lowest abuse potential and most amount of medicinal needs. So our atypical benzodiazepines like Lyrica, and then some of our cough syrup with codeine, okay? So that's kind of the scheduling thing. Now, in terms of scheduling or looking at medicinal use, criteria for a drug to be a medicine has to fit several different qualifications, all right? When generating a molecule that you want to get marketed, the chemistry must be known and reproducible, okay? So you have to be able to publish your synthesis pathway as well as publish a molecular structure of whatever you're using. Have to perform adequate safety studies, as we talked about in the clinical trials talk. Well-controlled studies proving efficacy, same there. Accepted by qualified experts. So each time you finish a clinical trial, regardless of which phase you're in, you will publish it in a journal, New England Journal, JAMA. Those are big ones for the bigger marketed or market value drugs. But they have to be evaluated and then accepted by experts in the field. And then on top of that, evidence widely available. So same thing, you publish your findings from your clinical trials, you let everybody take a look at it, you know, an open book with your data and show that this drug has the intended use and is safe, etc., etc. But these are the criteria that DEA and FDA use for approving drugs for medicine. And to that end, as an excellent example of how, you know, what an efficient machine the federal government is, January of last year, the Department of Health and Human Services reviewed all of the evidence that was relevant for rescheduling marijuana, and then sent a letter over to the Department of Justice and said, DOJ, it's time for a adequate and realistic scheduling for cannabis. And the DOJ actually said, yeah, you know, you're right. Let's talk to someone about changing from Schedule 1 to Schedule 3. So the DOJ reached out to the DEA and they said, you know, HHS and us are saying this, and the FDA's on board. The population's been on board for 2 or 3 generations, so let's have a meeting. So they set a hearing for December 2nd of last year, and that came around and they delayed the meeting until January 21st of this year, and then they delayed it again and have no scheduled meeting for the foreseeable future as of 2 days ago. So I gave this slide last year in the fall and said I'm hoping after December 2nd I can update this and we'll have a new schedule, blah blah blah, but that's going to have to wait because here we are a year later and we're still at the same place, and that's fine, but that's how it works, and that's it for today. So let me know if you have any questions or concerns.